Bismillah ar-Rahman ar-Rahim. Alhamdulillahi Rabbil Alameen. Now, dear students and house officers and those who are appearing in the membership or fellowship examination on third year and fourth year students. Now, we are actually previously discussing one by one in slightly more detail about the complication associated with the cirrhosis of the liver. One of the complications is the spontaneous bacterial peritonitis. I am Professor Syed Ali Haidar and I am the Honorary Professor of Medicine and globally on the line without any fame or without any economics involved. For the people, for the sake of the beneficiary, I am working. And for the higher conception, rather the leading conception of the medicine, I am working for it. Now, what do you mean by peritonitis? Is the inflammation of the peritoneum. You know that there will be many types of the bacteria and the peritonitis. It may be, what is called as a traumatic type of peritonitis. It may be spontaneous peritonitis. It is spontaneous. It is not associated with any rupture or any inflammation or any traumatic injury, etc. It is spontaneous. Means there is nothing significant before it for the initiation. It is associated with the cirrhosis number 1. It is always associated with some of the oozing of the fluid in the peritoneal cavity. It should be associated. The दो शर्तें हैं, स्पॉन्टेनियस हो, दूसरी ये कि कुछ यूजिंग होनी चाहिए. बिल्कुल ड्राई पेरिटोनियम में ये नहीं होता कभी भी. इसके लिए जो है ना वो स्पॉन्टेनियस बैक्टीरियल पेरिटोनाइटिस दे आर एसेंशियल ऑफ डायग्नोसिस. दे आर सस्पेक्टेड, फर्स्ट ऑफ ऑल suspected secondary bacterial peritonitis. Secondary bacterial peritonitis is the peritonitis with inflammation near the peritoneum. The peritoneum is covered all the viscera. If you are dealing with the bacterial peritonitis which is spontaneous, it means that the secondary bacterial peritonitis should not be there. It is primary bacterial peritonitis. The two important things is the polymorphonic count should be more than 250 cells or the WBC count should be more than 500 cells. Two important parameters. Thirdly, if you culture, there are multiple organisms in the ground stain and culture. And anaerobes which are cultured. The two of the following ascites criteria is that total protein should be more than 1 gram, LDH is upper limit of the normal for the serum, and glucose is less than 50 milligram. Because they consume glucose. In comparison with the random blood sugar, it is lower down. The treatment is that the third generation cephalosporin considered CT scanning abdomen pelvis, possibly laparotomy, if you suspect it, the secondary type of the bacterial peritonitis, but it is spontaneous bacterial peritonitis. Do not mix with this. This is primary peritonitis. Primary peritonitis. Spontaneous bacterial peritonitis is the development of the bacterial infection in the peritoneum, despite the absence of an obvious source for the infection. You don't know the source. It is specifically an infection of the ascitic fluid. This is important. Some ascitic fluid should be there. An increased volume of the peritoneal fluid, that is. Ascites is most commonly a complication of the cirrhosis of the liver. It should be associated with the cirrhosis of the liver. Or it may be associated in some cases with the nephrotic syndrome, where the liver weeps the fluid out. Spontaneous bacterial peritonitis has high mortality rate. Another point is that those people who have developed the spontaneous bacterial peritonitis, they can develop afterwards the tuberculous peritonitis. This is another study which has been proved in Pakistan and in India. The diagnosis of spontaneous bacterial peritonitis requires the parasynthesis, that is the therapeutic. It is not therapeutic, it is diagnostic parasynthesis. A sampling of the peritoneal fluid taken from the peritoneal cavity, and if the fluid contains more than the WBC, total body WBC 500 cells, or only neutrophils you will count more than 250 cells. For example, if the neutrophils are less, very less, 250 or less than 3, less than 200, then it is non-neutrophilic type of the spontaneous bacterial peritonitis. This is another version of it. Actually, the management is the same. And it should be a therapeutic. If you give the antibiotic, it will definitely you can manage it without culturing results. In addition to the antibiotics, the infusions of the albumin-free fluid should be given. Salt-free albumin, that is. It is also beneficial in these cases. It is a very important point that if you infuse the albumin in these persons who got the management also, they are well responded. Other life-threatening complications such as the kidney malfunction and increased liver insufficiency can be triggered by the spontaneous bacterial peritonitis because a lot of organisms are multiplying. And the end result are the protein derivatives, and they are absorbed and they will enhance the liver insufficiency by developing the hepatic encephalopathy. Where there are signs of this development, and albumin infusion will also be given. The albumin infusion should be given when you see there is kidney is also involving oliguria, for example, hyponatremia, then you will give the albumin infusion. Another type, which is so-called subtypes, is called spontaneous fungal peritonitis. It's rare, and this can sometimes accompany a bacterial infection, possibility of the fungal peritonitis, like actinomyces, like candida, specifically seen in those cases where there is association with the HIV, I will say. Now, spontaneous bacterial peritonitis, this is how the abdomen is flooded out, the flanks they are full, the all part is full here, lower down there is probably hydrocele, the umbilicus is definitely protruded out, its margins is there. You can go for the fluid thrill, you can go for the shifting dullness. Even the patient may arrive with the different type of problems or the clinical features. The etiology is that it is caused by the gram-negative. The most common organism is Escherichia coli, followed by the Klebsiella pneumoniae. And these organisms are present in the coliform bacteria, Enterobacteriaceae family, and they actually oozing also along with the fluid by diapetesis. So they will infect the peritoneum in this fashion. The common gram-positive bacteria identified include the species of Streptococcus, and Enterococcus, less commonly. More common is the gram-negative Escherichia coli and Klebsiella. A spontaneous fungal infection can often follow spontaneous bacterial peritonitis and treated with the antibiotics. The antibiotics you will give, then the fungal infection can occur, like candida, etc. The use of the antibiotics can result in an excessive growth of the fungi in the gut flora, which can then invade or translocate into the peritoneal cavity. Although the fungi are much larger than the bacteria, the increased interstitial permeability resulting from advanced cirrhosis make their translocation easier. By diabetes or the other movements of the intravascular to the peritoneal cavity, it is easy. Candida albicans is the commonest species which is involved. Specifically involved in those people who are diabetics or who are taking the steroids or who are chemotherapy or in cases of HIV infections. Pathophysiology, they said that the T antagonists and the proton pump inhibitors are medications, because these are the first lines of defense rather. They can counteract this infection, but excessive use can, in cases of cirrhosis, they are using these drugs in cirrhosis. It enhances this infection. The bacterial translocation is thought to be the key mechanism for the development. Small intestinal bacterial overgrowth, which may be implicated in this translocation, is found in the large percentage of these cirrhosis. With respect to the compromised host defenses, patients with a severe acute or the chronic liver disease are often deficient in the complement, hypocomplementemia that is called, and may also have the functioning of the neutrophilic and the reticuloendothelial system. It is malfunctioning of the neutrophil, it is malfunctioning of the reticuloendothelial system in the cirrhosis of the liver. And that is why the peritoneums are involved with infection. As for the significance of cirrhotic fluid protein, it was demonstrated that the cirrhotic patient has the cirrhotic protein concentration below 1 gram were 10 times more likely to develop the spontaneous bacterial peritonitis rather than the higher concentration of the protein inside the peritoneal cavity. It means less than 1 gram protein in the cavity are maybe the possibility of the predisposing factors. In nephrotic syndrome also, specifically in children, it may occur as isolated type of the spontaneous bacterial peritonitis, but it is not very common. The clinical feature is that the patient comes with you with a history of the chronic liver disease. Yes, fever, chills, nausea, vomiting, abdominal pain and tenderness, and general malaise. Altered mental status and worsening ascites. Why mental status is termed? Because of the multiplication of the bacteria and the protein derivatives which are derived from the bacteria, the nitrogenous substances. It will cause definitely the altered mental status, that is first or the second grade encephalopathy. 30% have no sign or symptoms. You will go for the examination, then you find there is some tenderness, and then you feel, you go for the temperature is higher than 100. In cases of acute or the chronic liver disease, spontaneous bacterial peritonitis is one of the main triggers for the hepatic encephalopathy. Remember this. Those people who have got spontaneous bacterial peritonitis and going to liver failure or hepatic encephalopathy, these are inter-associated factors. Always remember. These symptoms can also be the same for the spontaneous fungal peritonitis, therefore make a differential difficult. The delay of the diagnosis can delay the antifungal treatment, because you know that the fungi are very rare. So you miss out. Diagnosis, definitely you go for the needle aspiration, go for the count. If it is more than 500 total leukocyte count or more than 250 neutrophils per microliter or 10⁻⁶ per liter, then it is diagnosed. This is the main diagnostic criteria. It can be cultured, which type of the bacteria seen, and it can be sensitized with the different antibiotics. Management antibiotics, definitely the third generation cephalosporins are considered the standard, this gold standard treatment. So we give the cefotaxime, and these are the third generation and cephalosporins. Cefotaxime is the agent of choice for the treatment of the oral. It is oral drug and easy to administer. You can give this drug 400 milligram per day, starting with the 400 milligram BD for 3 days and then 400 milligram OD for 7 to 10 days. When there is risk of the kidney malfunctioning, which is associated, developing in a syndrome which is called the hepatorenal syndrome, which may be associated, the IV albumin is usually administered too. So we give the albumin also, if there is a chance of the hepatorenal type of effect. Prokinetic agents should be used because they will go for the reduces the incidence of spontaneous bacterial peritonitis, because they will decrease the small intestinal bacterial overgrowth. Intravenous albumin, I have already said that it is beneficial. So this is the main management we have about the spontaneous bacterial peritonitis, SBP. Remember this. These are few words which I have said about the spontaneous bacterial peritonitis. You should remember the essential of diagnosis, the diagnostic criteria, and the management criteria. I hope that you can understand now, and we will go with another complication inshallah in a few days. وما علينا إلا البلاغ. السلام عليكم ورحمة الله وبركاته.